Hello, everyone. Can you hear me? I'd like to welcome you to this session. We really want to thank you for your participation today and for all you do, because I know you wouldn't be here if you weren't a passionate leader for equity. Hopefully, you will understand the reason we've selected this title and highlighted some words in it. Prevention and optimal disease management for sustainable, healthy communities in every zip code. But let me quickly remind us, as if we needed a reminder, of the why. I downloaded these COVID data today. If we focus on Black populations for a moment, hospitalizations and deaths remain disproportionately high compared to the white population, yet vaccination rates continue to lag. But it's not just COVID. Let's look at diabetes. Diabetes rates, hospitalizations, deaths, amputations, end-stage kidney disease are many times higher in Black population than their white counterparts. Indeed, our own research that will be coming out later this year shows this trend in the Medicare program. Cancer deaths, too, are much higher in Black populations than in white. What is this attributable to? Lower rates of screening, delayed treatment, lack of access to clinical trials and latest therapies? We'll learn more about flu vaccination disparities in a moment, but if you think it doesn't lead to bad outcomes, take a look at this slide, showing how much higher hospitalization rates among Black populations due to flu were. The bottom line question or questions for me and this session is what can be done to promote overall health sustainably in underserved communities of color? What can we do? I wanted to remind you all of SHC, that it is indeed our mission to promote this very objective. And here's our team. But we can't do it alone. We need you to become a part of this effort in your community. We've recently received funding from the CDC to promote vaccination, basically by giving you resources and training and support to do so in your community. So I would ask you to please sign up to be an NMQF Health Champion. It's all about your commitment and passion. All of us can make a difference in this pandemic with flu vaccination, with health promotion overall. We have and are developing a ton of resources and opportunities for training and indeed leadership. Sign up and we can work to promote sustainable health in every zip code. We're really blessed to have the help of some dedicated and brilliant individuals here today to inform our discussion. Starting from the bottom, it's my deep privilege to introduce Dr. Ada Stewart. She's a family physician in South Carolina. She is president of the American Academy of Family Physicians. She holds leadership posts from the local to the national level. And in the aftermath of 9/11, Dr. Stewart enlisted in the US Army Reserves, achieving the rank of colonel, I believe. Second from the bottom is our youngest member of the panel, Sai, and I'm going to try to pronounce this correctly, Naduchazian. Sai's an MD, MPH student at Tulane and a program manager for the Healthy Heart Community Project there, and a protege of Dr. Keith Ferdinand. He's an impressive young man, and I believe his generation and people like Sai are going to get us over the finish line in terms of health equity. I'm lucky to call Reverend Dr. Terris King a colleague and a friend. He's a pastor in Baltimore and a community powerhouse in the city, effectively pulling together and leading his fellow pastors in the city, along with community health organizations and researchers. His efforts actually raised flu vaccine rates in Baltimore this past season. Terris, previously the deputy director of the Office of Information Systems and acting director of Minority Health at CMS, is energetic, people and community centered, and he gets it done. Donney John is another remarkable panel member, linking commitment to innovation. Dr. John is the executive director of Nova ScriptsCentral, a nonprofit pharmacy that provides life-saving medications to uninsured patients in the Northern Virginia area. He also serves as the chief clinical officer at Pharmacist Partners, leading hospital transition and care and employer solution programs. He's a practicing pharmacist, entrepreneur, patient advocate, idealist, a creative leader, and chair of the NMQF board. Finally, I'm honored to introduce my friend and amazing researcher, Dr. Salah Mahmud, who uses his training and statistical genius to tease from data real meaning to inform change. Yes, with his many titles that you can see and that I've abridged, he is passionate about promoting health, especially among underserved populations. He will start us off with a presentation of data we look at together about health disparities. But before I hand it over to Salah, a little housekeeping. We want you to be part of the conversation. So please place questions in the Q&A box, especially as we move through the conversation. And don't put it in the chat box because we may not be able to find it easily. So Salah, I'm going to turn it over to you. Thanks again, everyone.
Thanks, Laura Lee, and thanks everyone. And I hope everybody could hear me clearly. So my task today is to briefly outline the results of research projects that we finished recently, looking at the effects of race and ethnicity on influenza vaccine uptake. As you all know, the influenza vaccine is the only effective public health intervention that we have to reduce the risk of influenza, which is like COVID, has over the years affected more minorities than whites in terms of complications, hospitalizations, and deaths. This is a project that was published recently, so if at any point you want to look at the paper yourself and the associated editorials, just point your phone camera at this QR box here, and you will be taken directly to that website, and it's free to download. So this was a national cohort that consisted of about 26 million Medicare beneficiaries. All of them were 65 years of older during the 2015-2016 flu season. What we did is we looked at the uptake of the flu vaccine by ethnicity, but we also looked at other factors like region where people lived and their income status. As you can see from this busy chart here, that Blacks, the yellow, the blue bars here, consistently, regardless of where they lived in the country, they had between 32 to, I would say, 45% lower chance of getting any flu vaccine compared to whites. Hispanic communities also have a similar trend, although it's not as severe. The gap is not as big as with the Black communities. Asian communities generally fared better when it comes to getting any flu vaccine. And you could see here that getting a low income subsidy helps narrow that gap, but it doesn't close it. There is still people who got low income subsidies. They fared better than people who did not, but there's still a significant gap. Now, one common objection to findings like this is that minorities are less likely to get the influenza vaccine, maybe because of issues of trust, um, maybe because they're hesitant, at least more hesitant than whites to get the influenza vaccine, or possibly they're facing some uh, access issues. Uh, for example, ability to travel to a vaccination center. And all this is true to some extent. We know that from other studies, but I don't think it tells the full story. In this particular study, we were lucky to have um, a comparator of a new vaccine that was introduced by Sanofi, which is also the sponsor of this study, um, has the same indications as the regular flu vaccine. It goes by the name the high dose influenza vaccine because this particular vaccine has 4 times the dose um, of the virus that you would get if you take the regular vaccine. And it has been shown to be more effective than the regular dose vaccine or the standard dose vaccine in preventing severe illness, hospitalization, and death. It's also more expensive, unfortunately. Um, so this was an opportunity for us to neutralize all these factors, issues like vaccine hesitancy, because what we did, we compared people who got the high dose vaccine with the regular standard dose vaccine. Now, all these people had access to some vaccination facility, obviously, and they're not vaccine hesitant. They got the vaccine. Um, some got the HD and some got the standard dose. And as you could see here, even the Asians who did sometimes better than whites when we looked at the overall uptake of any influenza vaccine, when it comes to the high dose vaccine, uh, almost every racial minority had a much lower chance of getting the more effective high dose vaccine compared to whites. And you could see for blacks that went from about 42% to up to 64% uh, lower chance of getting the HD vaccine when vaccinated. And the same applied to all other minorities, except for some reason for Asians living in the South and in the Midwest. They had a comparable chance of getting the HD vaccine to whites. And as you could see here, the getting a low income subsidy didn't help narrow that gap. So the takeaway message from our analysis is that compared to whites, Black and Hispanic groups were between 20 to 40% less likely to receive the flu vaccine. Um, but even when vaccinated, about there is still a gap ranging from 10 to 50% um, for almost every racial minority in the US. Uh, Something that I didn't show here, but you could see it in the paper, that we tried to see if these differences could be explained by things like sociodemographic factors, income, for example, or by health status. And the findings changed very little, so we couldn't really explain why we still have these big gaps in uptake between racial minorities and whites in the US. And I will stop here, and I'm sure this is not a full detailed explanation of what went into the paper, simply because there is no time. But please feel free to go and look at the paper itself and the editorials associated with it to see the full extent of the work that was done there. And thank you very much for the people who helped make this project happen, Laura Lee and others at the NMQF and Sanofi. Thank you.
Thank you so much, Salah. So looking at that research using Medicare, so these were older people over 65, who should have been getting this vaccine. I'm going to invite the conversation now by posing some questions. And my first question is going to go to Terris, Reverend Dr. King. I want to ask you specifically about the toll of health disparities in the community you serve. Can the community you serve access vaccinations, diabetes care, cancer screenings? How would you characterize in 3 or 4 minutes the challenges for your community?
Thank you, Laura. First thing I would say is that things have gone in Baltimore from bad to worse as it relates to health. And as it relates to accessibility, that has been one of the issues we've really improved upon. I guess I would have to start out by saying it was during the flu season that I began this process working with you and working with Lois Prydema, Senior Director of Vaccines for Johns Hopkins International Vaccine Effort. So we went after, there were 3 things that we walked out of this with. Who do we work with in order to increase the flu vaccine rate? How do we work with them as we began to move through this process? And finally, we've ended up with what can we do to sustain the effort that we've really started. So let's go with the first part. When we first began just looking at the community, that issue, the issue that you raised, was one of the issues that they really put forward a lot, even during the flu process, because COVID was here. And part of what they said is, now you come to us about our health, but we were unhealthy before COVID ever came. So even during flu, it was a problem because many looked at the flu vaccine thinking it was a trick, and we were actually giving them or promoting a COVID vaccine that hadn't hit. And so they were hesitant. But once we found out who we should work with, almost as a general contractor, and if you hear background noise in my house, it's because there's reconstruction going on. But it was almost as a general contractor, and we looked at everything. We looked at, and I'm wearing a purple t-shirt, Divine 9. I'm wearing this both because Lois is a Pittsburgh fan and I'm a Ravens fan, but that's another issue. We looked at the Divine 9 as a group to work with. We looked at community centers. We looked at senior centers. But what we found is the key for us was the church, and not just any church, because it wasn't about size, it was about service. And it was really about those churches whose efforts prior to the campaign were community-based. Those churches who feed people, where people vote, clothe people, help people in terms of jobs. Those were the kind of churches that could work as general contractors with all of these other organizations to increase the flu rate, and we did in Baltimore, by about 15%. And I started out with my friends, a group of ministers, mainly within the Christian and Baptist religion. But I expanded that. When we went from flu, the infrastructure grew. When we went into COVID, what I really started to focus on was having an interfaith effort that included one of my best friends, who's a rabbi of one of the largest synagogues in the country. He came on board. And because of my relationships with the Nation of Islam, the Baltimore City Health Department, who sponsored us, really came into our sessions and it felt like the UN. We had rabbis, the Nation of Islam, bishops, pastors, and priests on one line, working towards one singular objective. So that's the who. And we're doing pop-ups around Baltimore with all of these groups. But how to work with them, this is a piece I want to leave you with. First, you have to understand the historical context of the group you're working with. Second, you have to listen. We've held constant listening sessions, both with congregations and with leaders. Understand the role of these faith leaders, create partnerships and be willing to share power, and then create solutions together. Don't come to us with the cake already baked. Make sure that we're involved in the beginning of the process. The last thing, and we wrote a paper in the Journal of Health Communications about this. The last piece I'll say is, how do we sustain it? How do we keep the effort that is already successful in Baltimore going?
Well, I'm going to actually stop you there, Dr.
Okay,
King,
great.
because you're going to get another chance at this. And I think that would be a great point to go to.
Beautiful, beautiful.
I want to turn to Donney now and ask him, you know, he has a lot of hats. He provides care to poor people in the community in Northern Virginia. He also thinks innovatively about the needs of underserved communities. So Donney, maybe you could offer a few thoughts about promoting preventive care and chronic disease management among these populations.
Thanks for the question, Laura Lee. You know, one of the big things we have to realize is that there's over 30 million uninsured people here in the US. You know, oftentimes when we look at the data, we're looking at insured populations, whether it's Medicare data, Medicaid data, or commercially insured data. But for the uninsured, which are all around us, and you know, it's the CBO had just announced that there was 30 million last year, and they're projecting, you know, because of COVID, that we're going to have an increase in uninsured in 2021. We need to figure out, how do we address these resources? You know, a colleague of mine, Annalisa Quinn, who's an executive director of Colmore Clinic, it's a free clinic that provides, you know, free medical care to the underserved in Falls Church. She and I were having a conversation about a concept she coined, time poverty. And it's a beautiful concept when you think about it. It's the time is a luxury not everybody has. Most of the patients that we serve that are uninsured are 300% below the federal poverty level. They work 2 to 3 jobs. They have to take care of their kids, their family members, and they have to, you know, take care of themselves, which they usually leave to last. They don't have enough time for it. So when we're building services that are focusing on, you know, chronic disease programs or preventative programs, are we making these programs available at the times that families and individuals that need it are available? You know, for example, when we do a lot of health education, and we do free health education in libraries, churches, any public venue you can imagine, we get invited, we show up, but we do these workshops usually in the afternoons, evenings, or weekends, because that's when the community needs it, not necessarily at 9 o'clock in the morning or at noon on a Wednesday. That's typically how things are often done. We create these programs, but we don't have the people that truly need these services showing up to them. At the same time, when you look at the diabetes prevention program from the CDC, it's touted as a well thought out program, has tremendous great results. But the problem is, how many people have the time availability to commit to that lengthy program? And that's the one thing that we need to look at, is that, are we designing things, you know, as Pastor King put it, I loved it, don't come with a cake already baked. I think that's really a true statement when we're looking at solutions. You know, a lot of the solutions that are coming out there, we're looking at the volume, especially from a nonprofit standpoint, being grant funded, it's about the number of people served. So when you look at that metric, every year you're looking at, okay, are you increasing the number? But then when you scale that back and ask, well, have you made a difference? What's the outcomes? You know, and I always tell people, it takes a lifetime to get sick, but also takes a lifetime of recovery. You don't cure your diabetes over a 6-month period or a one year time period. This is not a 1-hour medical drama, Grey's Anatomy episode that we solve all your life crises. You know, we really need to take time to understand, as Pastor King alluded to, that you have to build trust and you have to listen to what the community needs. When we talk about healthy food options, We can talk about that all day long, but do we really have the capacity in communities where healthy food is available? Is it affordable? You know, it's one thing to have staff benefits, but once again, there's 30 million uninsured individuals in this country that have no access to these programs. You know, how do we get them more informed and get them more engaged so they can be empowered? You know, no one ever chooses to be sick. I've yet to meet in my career one person that says, you know what, I'm hoping for a heart attack today. I'm hoping to get, you know, cardiovascular disease. We don't choose illness, you know, but what we don't have is the ability to get better, because sometimes we don't understand what are the tangible things. It's not necessarily taking the medicines, it's not necessarily going to the doctor's office, but in our day-to-day life, how do we find that balance where we can manage our illness and have the support of our friends and loved ones? We can't do this alone. We need, you know, support within our families and friends and our other networks.
Donney, I'm so glad you said a lot there. And, you know, kind of I heard it takes a lifetime to get sick. Nobody asked to be sick. And is there access to care, to support social determinants of health and education so that you can take control, which I think is a really excellent way to switch over to ask Dr. Stewart from her perspective. So you have a lot of hats. You're a leader, you're a care provider. So what makes you upset, or what barriers do you see for primary and secondary prevention among underserved populations of color? And maybe you could start even thinking about what opportunities there are.
Thank you so very much for this opportunity. And, you know, it's really important that I am a practicing physician and have the honor to be a leader of a wonderful organization, the American Academy of Family Physicians. And, you know, as we look at the COVID pandemic and as we go further, you know, I think about the fact that with crises comes opportunities. And so I'm looking at all the barriers that I see before me, and what are those opportunities that we can do to really take care of the patients that especially I serve and that many of us are concerned about. Individuals who were devastated through this pandemic, disproportionately impacted. You know, one thing that was already mentioned is access. We fail to think about the importance of primary care in all of this. Primary care physicians, in particular family medicine physicians, we take care of the majority of individuals. When we think about primary prevention, we give out more vaccines. We're looking at the COVID-19 vaccine. We've been doing flu vaccines. You know, we give out Tdap and all those things. That is what we do every day. And when they looked at the rollout for the COVID vaccine, they were looking at pharmacies and these mass vaccination sites that most of our patients of color, people of color, could not even access due to the social determinants of health, not having transportation to be able to get to these sites. But they failed to put a lot of money and efforts into primary care, into the community health centers. I work at a community health center, and we were one of the last to be able to get the vaccine so that we can be able to vaccinate our patients. Many patients look at primary care, and especially family medicine, as their trusted resource. And again, this is an opportunity for us to really invest more in primary care. We spend trillions and trillions of dollars in healthcare, but a small percentage of that is dedicated to primary care, 5 to 6%. And we have the worst outcomes in our nation, in particular in people of color. One of the other things I want to mention that is important is that we address the implicit and explicit bias that exists within the medical profession. And we need to address that, especially if we're going to be able to get to prevention in people of color, making sure that they're educated to know that certain individuals require certain screenings and that they're given that opportunity to be able to screen for those diseases. Another barrier is mistrust and distrust of the medical profession. And to be able to really look at that, we have to look at historic and also current, so past and present, there is still discrimination that is going on, and we need to address that. And we can address that by having a more diverse workforce as far as physicians and providers of care to be able to take care of our patients of color. And then lastly, with my a brief time that I have, I want to talk about funding. So much money is placed into areas that are not of the highest need. We need to put more funding into those under-resourced areas so that we can have the funding to be able to take care of patients and to take care of our communities of color, so that we can make sure that they have access and the availability of great health care that everyone so desires and so needs, so that we can do the job that we really need to do. And then with that, making sure that we have better data collection. Funding goes with, the data, making sure that we are able to, and we saw that with COVID, we were not collecting the data to show that people of color were highly, highly disproportionately impacted. And once they started getting that data in, folks were like shocked, but we know that most of us were not shocked. We knew that this was an issue. So again, with this crisis and with the crises that we have before us comes many opportunities. And one opportunity is to really put a lot of investment in primary care, in particular family medicine. So thank you.
I am so glad that you made the points you did. I wholeheartedly agree. We need primary care in the community, and you need to be hooked up with Reverend King and also with Donney John, the pharmacist in the community. But primary care is essential, but it has to be trusted, and the system can't be racist. And we shouldn't be afraid to call it by that name, or it's not a trust thing, right? Plus, let's put the money and the services and the resources where the need is. We know where the need is. And if you have good data, your last point, you really know where the need is. So I thank you for those points. I'm going to ask Sai now to talk about what he's been doing in terms of educating the community and promoting vaccination and diabetes and heart disease care.
Thank you so much, Laura Lee. So a little preview, Healthy Heart is an organization that I work for, and it's a 501c3 nonprofit organization that has been established in New Orleans for a really long time. And their goal is to eliminate and reduce cardiovascular disease disparities in predominantly African American communities where there's a high prevalence of diabetes, heart disease, and overall poor health outcomes. So I've only been involved for less than a year in this organization. And in my time, there are really three main takeaways that I've gotten from, vaccination efforts, diabetes education, and other initiatives that we've worked on in the past. Number one is really understanding the role of a gatekeeper in the community. So as an MD/MPH Global Community Health Sciences student, this is a concept that's really salient for me, because gatekeepers are organizations that work in the front line, in the community every day, day in, day out, and they really try to understand what is going on in the community. And they work with the people and they want to see where the health needs are, what can we do that would be actually influential, and how can we address them. So using the gatekeeper as our central starting point, we should also, like, academic and nonprofit organizations should follow their lead and support them, not overtake an initiative. So for example, we know that in the past that academic institutions have collected funding or resources, and they've gone into communities and dictated policy and tried to start community programs without really understanding what the community needs. But one of the reasons that Healthy Heart is actually really successful and has been really well established for more than 20 years is because we follow the community's lead. And specifically in the lower ninth ward, where we have multiple vaccination events, we take the lead of the gatekeeper organization, Sankofa. So for example, in this past November, during COVID time, we were still able to organize a small influenza vaccination session. Healthy Heart brought the resources for education and the vaccinator, Walgreens Pharmacy, to provide the vaccines. but we didn't go in and we didn't set up and we didn't start the event. We followed the lead of Sankofa, where they told us where to set up, how to organize, and how to approach the community members in a way that, you know, protects the community, but also in a way that's effective for the program as well. And as a medical student, I think this is a really important point in like early on in training. The earlier you can get started with working with communities and understanding community health disparities, the better it will be for the communities that you serve as a healthcare professional. We all know from, at least from my training, like in medical school, we've been taught that vaccines can be beneficial for health. And especially we know that influenza vaccination can stop the, like influenza disease, like acquirement. So that's a very important concept, but when we go into communities, we need to be able to translate that. We should not only communicate that, but we should also understand how much do community members know about influenza vaccination? What do they understand? What questions they might have? Do they have any barriers or hesitancy towards the vaccine? And really taking that time to answer the questions and seeing where the problems come from as a trainee will help us understand where do we need to go from here and what work needs to be done.
Great. Now I want to open it up for a conversation amongst all of you. And I also invite our participants to load in their questions to the Q&A box. I think you've kind of carved out the challenges and the issues. I would like each of you to kind of start talking to one another about sustainability. And also with the hat you wear, and Sai, the hat you wear is young trainee, by the way. What can we do? I mean, let's stop talking about this. I don't want to have this session in 3 years. I want to be celebrating our successes in 3 years in many communities. What are we going to do to get there?
Laura Lee, I'd like to start and have focused with Dr. Salah and Dr. Stewart. You know, when we look at guidelines to treat, you know, people of different ethnic backgrounds, you know, whether it's the JNC 8 guidelines or diabetes guidelines, it's always a little asterisk, you know,
Yeah.
Asians, you know, Native Americans, African Americans. So when we look at treatment, we have these great guidelines, but then the sub asterisks that puts the emphasis on minority health only as an asterisk and not as like the big bullet point when we are becoming a minority majority country. You know, how do you feel? What do you think your thoughts are about? Can we change that in terms of the treatment going forward? Can we make the focus on treating African Americans, Hispanics, Asians, Native Americans more of the top talking point when guidelines are being developed versus being a sub bullet point?
That's a great point. Please, Dr. Stewart.
So a couple things come to mind. Number one is we need to really kind of get away from race-based medicine and really focus on medicine for all and make it equal across the board. And part of that is really getting even to some protocols. Everyone gets this screening, this screening, this screening, this screening, you know, appropriate for your age, and not necessarily per your race or ethnicity. So removing that so that everyone, because we see that there's a problem when we do that, and that some folks are being left out when we have those little nuances to a particular guideline. And so those are things that we really need to focus on. The other thing, it comes with education of our young physician trainees, and making sure that they are aware of some of the myths and things like that that has perpetuated through medical training that has caused people of color to receive less quality of care. And I think those are two big things that really need to be addressed. Addressing number one, education, and also, you know, making sure that things are pretty much equal across the board so that we are not missing out on the opportunity to take care of people of color.
So I will say this, Laura Lee. Recently, I had the opportunity to sit before the House Ways and Means and to talk about this issue, to talk about what my former employer, Center of Medicare and Medicaid Services, should be doing. And this is the advice I gave them. I said, to serve African Americans and Hispanics in this country, those two groups alone, the actuary still reports that we are far more costly to the trust fund than other races based on our disease types, particularly Latinos who with diseases like diabetes live longer. What I said to them is that there needs to be an effort with FQHCs. Let's just stop talking about this issue of trust. Let's go where the trust and the accessibility lies. Let's make many houses of worship satellite based on the authorities of the FQHCs, satellites of FQHCs. If we're already giving vaccines, if our houses of worship are clean enough and pristine enough to give a vaccine, why can't we teach chronic disease prevention and chronic disease management? Why can't these pastors and congregations have billable services that would go to my former agency? Why are we being used only in an emergency situation? But when the emergency resides, the access and trust will no longer be talked about. You are going to need these houses of worship. Our governor in Maryland recognized it. He skipped the health department and came directly to pastors to resolve the access issue. And it has worked. For people who are religious and non-religious, our doors are open.
So I want to, Salah, are you raising your hand? Go ahead.
Yeah, I think these are all great points, but a reminder from Canada, where we have a lot of those systems in place. We have, Medicare for everyone, and a system that's structured at targeting minorities. Like, for example, during the corona vaccine, minorities were a priority group, along with people, for example, with chronic diseases. But we are still seeing the same issues in Canada as well. And I think that goes to the fact that the roots of the issue are very deep. They are historical, they are structural, they are built into the system. And so there will need to be significant changes, I'm afraid, Laura Lee, that might take 3 or 4 decades or generations before a solution, a real solution for this problem can be found. For example, the underrepresentation of minorities in the healthcare professions. That's a problem, again, can't be solved overnight, but it's something that will go a long way into improving the relationships between, minorities and the healthcare system, and into putting the concerns of minorities into the forefront of the healthcare system planners and healthcare providers. For me, as someone who monitors these issues, I think an easier win, I hope, is to get rid of the system that we have right now for classifying people based on the color of their skin. This is an archaic system. It was a good small step when it was introduced in the 90s by the Clinton administration. But I fear that it masks a lot of the real gaps and differences between the communities themselves. The numbers that I've shown you I am sure are much bigger when you actually look down into specific communities. I know, for example, the Arabs are grouped within whites. And during the COVID, this was a clear problem where the Arabs had the same level of mortality and morbidity from COVID as any other minority in the US, but they were still grouped as whites. The system that we have right now that's used by all federal organizations to collect data is archaic and need to be updated to be more nuanced and to reflect how people think about themselves. So it's a big problem. It's going to take decades probably to fix, but there are a few things that we could move on, quickly.
If you don't mind me offering up a comment before raising something that's not going on in the chat box for you all, is I always had a simple-minded idea, because you know what? I don't want to wait decades. I'm sorry. And I know you're probably right, Salah, because you usually are, and Dr. Stewart. But when I look at all the topics I work in that are primary care related, a root cause of many of them has to do with obesity and lifestyle change and access to healthy food. I mean, you could go, and so I am a person who is obese, so I struggle with this myself. I know this isn't easy to do, but it underpins so much, ill health, diabetes, cardiovascular disease, probably cancer risks, chronic pain, osteoarthritis. I mean, I've just named like the top, killers of Americans, right? And I feel like that if we could get the primary care groups working with groups like Terris, but others as well, because they haven't heard you preach, Terris, but not everyone goes to church. But if there was some kind of way in pinpointed to communities of color and need, that we really got the support and the accessible healthy food to people in a sustained fashion, that we might be able to move that health needle across a lot of diseases. Is that a foolish notion?
So I would love to comment on that. And, it's really important that we really use our primary care physicians in a way, because we are part of the communities. But we have to recognize, as we talk about obesity and healthy eating, these are part of a system, the system within the communities that we need to really address. I work in practice in an area where there's no healthy grocery stores. There is a lack of transportation to even get to those. There's no safe place to exercise. And as we talk about so many of the issues that are going on within our country, one cannot even safely walk down the street to get part of exercise if they're part of, the communities of color. So this issue, when we talk about obesity and some of the social determinants of health, really are a lot deeper than this conversation that we're having. And so we really need to work with our political folks to, again, gain access and put more money and resources in the community, work with our community partners to address these very issues, get a grocery store, get access to healthy foods, get an area that is safe, take care of take care of people of color within these communities so that they can have the opportunity to live a healthy life and have an opportunity to have healthy, I always talk about healthy lifestyles and getting on that journey to their for their health, but recognizing that I'm talking to folks that really are limited, and also with money, just having the resources to be able to purchase a lot of things that we consider healthy. So it's really a lot deeper. We need to make sure that money is put into all these resources. And again, as was mentioned by myself and one of the other panelists, collecting that data so that we can put the money in these resources that are most needed. And only then will we be able to really impact the things that make chronic diseases worse or bring chronic diseases into to have a higher prevalence in people of color. And I think that's really important.
I
I'd
see
like to
that,
add,
Donney,
sorry,
please
Leslie,
go ahead.
I'd like to add to what Dr. Stewart was saying. I think, I agree, there needs to be more funding towards solutions. But I think when you put the funding towards solutions, they need to be culturally competent solutions. A lot of times we're throwing money at the problem, but we don't solve anything, where we're assuming that we know what the community needs. We were working with some food pantries last year to do educational workshops, giving them fresh food, fresh produce, and then they didn't have a way to cook it. So we had to think about, all right, how do you use a microwave? How do you use what's at your disposal in order to make that food that we're providing for free meaningful? So, but we have to understand the culture. When's the last time we've seen a diet that's specific to ethnic minorities? We pass out the DASH diet like it's going out of style, telling everybody limit sodium intake, limit this. But when we look at ethnic cuisine, there is a lot of salt, there is a lot of carbs. There are so many different things that food is part of the culture. And we have to address not only just the ethnic component of it, but also when you look at the food culture from the North, the South, or the West Coast, food is a common thing, right? We all bond around it. And then when we make recommendations, in the medical, team, it's always about limit your carb intake if you're diabetic, limit your sugars, limit your sweet tea. But guess what? This is what people, like Dr. Stewart said, what people have the ability to go out and purchase with the limited income that they have, and also the limited resources. When you go to a giant grocery store or Albertsons or Safeway, any of these grocery stores, there are beautiful nutrition programs where you can work with the diabetes educator, get food tours. But guess where most of these people, the patients that really need it, are going? They're going to the local bodegas, the halal markets. They're going to community-based, food vendors, sources. But do those business establishments, do they have the nutrition capacity to advertise healthy food options? Are they financially incentivized, to promote healthy food options as a thing? That's not the case. So we need to really look at it. If we're going to put money towards resources, they need to be valid resources. They need to be culturally competent. That's being built with the community. As Pastor King pointed out, you have to talk to the people that need the services and build it with them. Don't bring that cake to the party and then say, oh, I didn't know you were allergic.
Oh, well, you know what? We shouldn't be talking about cake here, I guess. I need to ask you this question because there's some discussion going on, and it's really about racism in the system, in the culture. So I wonder if you all could say a few words about how we uproot racism.
So Lorley, I want to say this. So COVID has given me an opportunity, no matter how unfortunate in my community, with the just crazy amount of funerals that I've done, okay, that have kept people apart and not allowed them to mourn in the normal way. But what it has given me an opportunity to do is to talk to pharmaceutical companies and researchers all across the country. And on this issue of racism, what I say to them is, I don't care if you're empathetic. I don't care even if you're racist. As long as it can be totally about return on investment, as long as you help my people. I'm not going to uproot that issue. I don't have time to wait generations. I'm on the ground. My people are dying now. I don't have the luxury of generations to go. So what I say is, let's look at their needs. Let's listen to them, as John said. They will tell you what they need. They need food. Okay. So I don't have to wait for somebody to come along and do something about social determinants. Like many other community churches, I feed them. So they can't walk in a safe space. So now I have walking tours with the police department, guarding them for safety. I will do what they say is their need now. This is not an academic exercise, because my people need service now. And you were right before. I need to partner with people like this primary care doc. I need to partner as well with the pharmaceutical industry because my people are not interested in anything but results. Be a racist, but help my people.
We only have a couple more moments here. I don't know who wants to follow Dr. King here.
I'll just say something real quick. You know, the really important thing is that we look at racism as a system. And so many times I have to tell some of my colleagues who say that, you know, I'm not racist or why are you calling me a racist? You know, it's the system that we have issues with, and we need to address that system. And it's not just on the individual level, and so we shouldn't individualize it, but we have to recognize that this system that we are dealing with now, it's racism, and we have to name it and then address it and deal with it.
And I fully agree. I don't, you know, think that it's very helpful to make this into an issue of white against black, in Canada of, you know, European Canadian against First Nations. But we need to recognize that the structures that are in place are designed to disadvantage certain communities. And that's where the permanence problem is. If you look at a map of a smallpox in my city, in Winnipeg, that goes back to 1920, it's very similar to the map of COVID disease in 2020. The same areas, the same
Right.
people are affected. That has nothing to do with individual racism in the street or somebody shouting racial epithets. It's the system. That's how resources are distributed. That's how people are cornered in parts of the city where the only option for them is to go out and get these diseases. That's the only possibility for you if you live in downtown Winnipeg. Everything we talk about in terms of prevention, etc., just don't apply to you. And that's where the real change has to happen. Governments, people have to realize that, you know, the game is rigged, and there has to be a deep structural change. Meanwhile, we have to fix the ongoing problems, but I am afraid that in another 100 years, we'll be looking at the map of another pandemic. It will look exactly like the COVID-19 map.
Shame on us then, right? Shame on
Yep.
us then. I can tell you that there are a lot of folks in the Q&A and chat who are, I think, morally outraged by racism, including among providers. So I think there's a lot of pain. I think there's a lot of discussion to have on this topic. But if I was going to summarize things, I think that respecting people in their communities and focusing on those communities and needs, engaging with them in an honest, ongoing, steadfast fashion in connection with their primary care providers, which can include in pharmacy in many communities and community groups, that is probably the quicker way, the near-term way to move the dial. Would you not agree? Well, and I'm going to just show this slide again to, excuse me. I think this is exactly what we want to do, that everybody who's on this call, all 120 some of you, that we could all be a part of that work of engagement in communities of need to identify and brainstorm and implement solutions in your community. I urge you to help us. These are big problems, but maybe we can make a start of it that's significant. And we could even look back to this day in a couple years and say that maybe this panel and the people who are participating in the Q&A had something to do with that. I really thank you. Oh, I'm sorry, go ahead.
There's just one resource I wanted to share. You know, it's something that Dr. King had alluded to about the importance of explaining the ROI, the return on investment for doing services. It all comes back to funding and money. So if you can't make the business case, no matter how passionate you are, it's not going to help. So today there was, I just came across a playbook that was put out by the Building Healthy Places Network, and it's called the Community Economic Development and Healthcare Playbook. So I put it in the chat, and it is an excellent playbook that highlights specific examples that are happening all around the country where communities have been engaged and cross-sector collaboration between the business sector, the healthcare institutions, and community-based organizations. I think one thing we all need to get better at is learning how to have that business conversation where we have to be honest and upfront. People want to make money. You can't deny it. You're not going to stop it. But you got to figure out how do you work with the system instead of just being against the system. Because a lot of people can give woke statements, talk about clapping for healthcare heroes, talking about every other buzzword around, you know, social determinants of health, patient-centered medical home. But where are we right now compared to when these buzzwords have been happening for the past 20 years? You know, the joke I have with people is that when we talk about intermittent fasting, I'm like, go to a poor person. That's what they've been doing their whole life. Intermittent fasting is not something that's like this novel concept to people, you know, that are uninsured or poor. This is their day-to-day survival. But now it's a fad that, oh, this is how I can manage my diabetes. But the reality is that it works for some people, it doesn't work for others. But we have to get more comfortable at providing action-oriented solutions that are focused on working with communities and keeping people engaged, and, you know, and really have that honest dialogue moving forward.
Thank you for that. And we will make sure that our champion training resources will include that element, because of course it takes money. Any last words beyond
Great
that?
Conversation. Thank you.
Thank you all for your service, for being here,
Thanks,
and
everyone.
for the good work you do. Thank you.